Adult chest pain, you're comfortable. Adult narrow tachycardia, there's 3 buckets. Easy. Adult STEMI, you know what that looks like. You know the mimics, you know the equivalents, you know all of that. But run an EKG on a 6-year-old, and suddenly everything you thought you understood about EKGs feels unreliable. The intervals look strange, the T waves look wrong, the rates are much faster, and the axis looks bizarre. Your confidence is more tenuous now. Here's the problem. If you apply adult EKG rules to kids, you'll mislabel normal as dangerous, or worse, miss what actually matters. Let's walk through a real-world style scenario and use it to dismantle some bad habits. I'm Angry Bill, and this is pre-hospital wisdom. This channel doesn't exist to tell you what to do or how your service wants it done. It's to sharpen how you think, to question assumptions, understand the physiology, and make better decisions when the algorithms run out. This is part of a series of pre-hospital scenarios that lead to discussions and lessons. I hate when social media shows me a cool x-ray or an EKG and then I never get to see the answer. So I'm not going to do that. I'll give you some story, pause for you to consider, and then discuss. Let's go. Let's run a scenario. You're dispatched to a 6-year-old male, chest pain and shortness of breath. The caller's the mother. The child recently had a viral illness. Awake and talking. Chest pain in a 6-year-old. If this is an adult, your brain would immediately jump to things like MI, PE, arrhythmias, and so on. But slow down. This is a kid. You arrive on scene to find the child sitting upright on the couch. There's mild respiratory distress, looks anxious but interactive. Skin's warm, no cyanosis. Mom's hovering. She's appropriately stressed, I guess. His heart rate's 132, respiratory rate at 28, blood pressure 98/60. He's set at 96% on room air and has a temperature of 37.9 Celsius centigrade, whichever one it's supposed to be. Already your adult brain's a little bit uncomfortable. 132 is a heart rate? That's tachycardic in adults. In a 6-year-old, I don't know, might be completely normal. Might be a little high, not scary high. Pediatric heart rates aren't adult heart rates. Normal resting heart rate ranges are like newborn is 100 to 160. In 6 to 12 years, where this guy is 70 to 120. It could be a little bit higher though with fever and anxiety. So 132 could be anxiety, could be a little bit of fever. Maybe he's got a little dehydration, could be pain. This is why pediatric EKG interpretation is much harder. That 132 is about equivalent to an adult having a heart rate of 105, 108, something like that. Yes, it qualifies as tachycardic, but is it scary tachycardic? If an adult had a heart rate of 132, that's a problem. With the 6-year-old, the rules have changed. The context matters more. So with pediatric EKGs and pediatric rates, there's no single adult-style cutoff. So you place the 12 lead, and now things get interesting. So let's go ahead and talk about this. One of the first steps of interpreting a pediatric 12 lead is to really deeply consider your pretest probability of finding something helpful. Why are you placing that EKG? Why are you complicating this call? Now granted, an EKG is non-infectious, non-invasive, it's really inexpensive, and it's not painful, especially when they ain't got chest hair. But on the other hand, there is time and synapses that could be used on other tasks that aren't being done. And so you're going to get this 12 lead that you maybe can't even fully interpret. It becomes a difficult choice. How much do you think there's going to be something found on that EKG? Right? So if you think you need to find it, go ahead and run an EKG. In this case, someone hands you a 12 lead and it's a sinus rhythm with the heart rate of 130. The PR interval looks pretty short to you. The QRS is narrow. The T waves are inverted in V1, V2, V3. There's slight rightward access, and your brain has to work through a bunch of decisions. Are those anterior T wave inversions? Is this ischemia? Is that right heart strain with the right axis? Let's start with the T waves. This is a juvenile T wave pattern. This is where the adult rules betray you. In children, T wave inversion in V1 through V3 is often normal, especially up to the age of 7. Sometimes it even extends into V4. This is called the juvenile T wave pattern. That pattern can extend even into adulthood, at least early adulthood, and it's called a persistent juvenile T wave pattern. The reason for that? The right ventricle dominates early in life. There's a gradual transition towards adult repolarization patterns during adolescence. It's completely physiologic at this kid's age. If you apply adult STEMI or Wellen-style thinking here, you're going to overcall that. The pediatric EKG literature consistently describes T-wave inversion in the right precordial leads as normal in adults and even into early teens. There's progressive normalization during adolescence. It's discussed in many books, and it's even mentioned in this version of Chow's that I have here. Chow's? Sorry. Anterior T-wave inversion in a child is normal until proven otherwise, not ischemia until proven otherwise. That's a mental flip from adult medicine. The second teaching point I want to go over is that intervals change with age. In adults, a PR interval greater than 0.20 or 200 milliseconds is considered prolonged. Greater than or equal to 0.12 is wide in a QRS, and the QTC intervals, or the QTC thresholds, are relatively fixed. In kids, everything shifts with age and heart rate. Faster baseline heart rates shorten intervals. The normal PR interval varies by age. QT norms vary by age and gender. If you don't know the child's age-specific norms, your interpretation becomes guesswork. This is why pediatric cardiology uses age-based reference charts. In the field, you rarely have those. So what do? You stop obsessing over millisecond perfection and focus on, is there something on here that's grossly abnormal? Is it clinically correlated, and is the child unstable? Pay attention to your patient, not the monitor. Treat the patient, not the equipment. Fix the child's problem. Don't fix the EKG. So this child's chest pain worsens with a deep breath. There's recent viral illness and a low-grade fever. The EKG is sinus tachycardia with a juvenile T-wave pattern. There's no ST elevation, no reciprocal changes. Now ask yourself, how common is primary coronary occlusion in a 6-year-old? It's extremely rare. As a matter of fact, most cardiac problems in children is due to respiratory crosses rather than plaque rupture. Children do not commonly have STEMIs. When pediatric cardiac pathology occurs, it's usually congenital or structural disease, myocarditis, pericarditis, cardiomyopathy, channelopathies. It's a different world. So this is a third teaching point. Congenital heart defects or congenital heart disease makes EKGs weird. Now imagine if this child had tetralogy of Fallot, especially repaired tetralogy of Fallot or atrial septal defect repair. There's a single ventricle physiology or prior cardiac surgery. You could see bundle branch blocks, axis deviations, ventricular hypertrophy patterns, surgical conduction changes. And guess what? They may be baseline for that patient. If you interpret those as acute findings without context, you'll escalate unnecessarily. This is why in pediatric EKGs, comparison to baseline is golden. What's the child's baseline when they have a congenital heart defect? And in pre-hospital care, you rarely have it. So humility becomes a part of your practice. What actually matters in the field? Let's zoom out. What kills children? It's usually not primary coronary occlusion. It's usually respiratory failure, hypoxia, shock, sepsis even, trauma. And here's the good news. Children are resilient. They're tough. They compensate aggressively. They respond beautifully to oxygenation, suction, and ventilation. Most pediatric tachycardia is physiologic. Most pediatric chest pain is benign. Most pediatric EKG abnormalities are developmental. So my practical field approach, when you put a 12 lead on a child, ask yourself, God, why did I do that? But then move on. Is the rhythm sinus? Is the rate appropriate for the age? And is there evidence of dangerous arrhythmia like PSVT? Is there profound QT prolongation? Is there high-grade AV block? And is the child unstable? You're not looking for STEMIs like you would with an adult because you'll almost never find one. Oxygenation matters more than EKGs. Back to our scenario. You provide supplemental oxygen, calm reassurance, IV access, and transport. The chest pain improves. Heart rate drops to 110 once the anxiety settles. His breathing slows. That's pediatric medicine. Support the physiology first. Children often fix themselves once you remove stress and improve oxygen delivery. So let's talk about some common pitfalls. Number one is overcalling juvenile T-wave inversion as ischemia. Another is labeling pediatric tachycardia as pathologic. You don't want to overreact to right axis deviation or apply adult interval cutoffs. Don't forget fever raises heart rate. Don't forget anxiety doubles heart rate in kids. And the big ones is projecting cardiology, projecting adult cardiology onto pediatric physiology. They're not small adults. Pediatric EKG interpretation in the field is difficult. The normal ages are age-dependent, congenital variations exist, developmental repolarization patterns exist, and you rarely have a baseline comparison, which means your job isn't about perfection. Your job is to recognize clearly dangerous, clearly unstable, or clearly compensating issues. Everything else, you stabilize, you transport, you reassess. This is your job. This is what we're good at. If adult EKG interpretation is pattern recognition, pediatric EKG interpretation is pattern restraint. Resist the urge to diagnose adult pathology in a child. Remember, kids are tough, STEMIs are rare, oxygen fixes a lot. Support physiology first. You don't need to be a pediatric electrophysiologist in the back of an ambulance. You just need to recognize what's truly abnormal. And don't forget the juvenile T-wave patterns. Leave the rest alone. Don't stress. Do your best. If this kind of structured clinical thinking is helpful to you, stay around. There are a few other EKG discussions on this channel, a lot more helpful than this one. I'm Angry Bill, and this is Pre-Hospital Wisdom. I want to thank you for spending a few minutes with me. If this helped your thinking, challenged a habit, or gave you something you'll actually use on shift, do me a favor, hit like, subscribe, and share it with someone who could use better information too. That supports what keeps this channel focused on making clinicians sharper, calmer, and harder to trick. I appreciate your time more than you know. Until next time, don't stress. Do your best.